Listen, well, thank you. Thanks, everybody, and thank you so much for doing this.
My pleasure.
But, as I mentioned to you, I'd like to start this at the beginning. So imagine, I know it was just a couple of years ago, but imagine when you were, just tell everyone a little bit about where you grew up, which I think your accent will betray it a bit,
Right.
but a little bit where you grew up and what you were studying when you got to college. Again, I know it was just a couple of years ago, so.
Yeah.
please.
Well, so I was born and raised in Brooklyn, New York. That's his accent. I think, like probably many of you, I was not really certain about what career direction I was going to take. But from my family background, my mother and father were very much interested in public service and doing things for the community. My father was a pharmacist. And back then, a long, long time ago, the pharmacies were not like CVS and Walgreens. It was kind of like the neighborhood community physician, psychiatrist, pharmacist who served as a somewhat of a pseudo doctor physician for the community. So I had this growing up in an atmosphere of serving the public with very little interest in financial remuneration. The pharmacy didn't do very well. He didn't make out too well. I think that the issue of public service and how that related to my going into medicine started to get really realized in my high school training. I went to a Jesuit high school in Manhattan, Regis High School, which was an all-boys school, and the motto of the school was "Men for Others." In other words, how you can contribute to society, and with very little concentration on your own self-interest. And it was in that atmosphere that I was trying to decide what I wanted to do. So it was very much of a classical background, Greek, Latin, a Romance language, and enough science if you were interested in doing something in science and health. I continued that, interestingly, having decided that I likely would want to go into medicine as my avenue of serving others. But I had a very strong interest in the humanities that I was trying to reconcile my interest in humanities and yet going into a science-based profession, which was medicine. So I took a very interesting course at Holy Cross, another Jesuit school that I went to, that I don't think that this exists anymore. And I always want to describe it because I think it was somewhat of an oxymoronic course. The name of my major was Bachelor of Arts, Greek Classics / Philosophy Pre-Med.
Wow. How did you fit that on your, it'd be hard to fit into any application
That's
form,
right.
so exactly.
Right, but it was really, when we did, the usual Greek and Latin and
Right.
many, many credits in philosophy, philosophical psychology, metaphysics, all that, and just enough science to get into medical school. And that's what I did. I went to medical school, and, I don't want to spend time going through all my career, but I think one of the questions that you were suggesting would be asked. I went into medicine with the purpose of doing something in medicine that is very different from what I wound up ultimately doing. So when people ask me, what is the lesson that you can tell us about your career? Probably the most important would be to expect the unexpected, because your career direction is almost never linear. In some people it is, which is fine, but in others, you go and get training in one direction and then opportunities present themselves. So my absolute purpose of going to medical school, doing an internship and a residency and a chief residency, was to go back to New York City and practice medicine on individual patients in New York City, somewhere between 68th and 72nd Street, between York Avenue and 2nd Avenue, which is right where the New York Hospital Cornell Medical Center was, where I did my training. And I thought that that would have been a very good career. And probably if I did pursue that, I would have enjoyed it very much, because I enjoy very much taking care of individual patients, which I've done over the decades to thousands of patients. But my career took a different turn when I did a fellowship in infectious diseases and immunology at the NIH, which gave me my first introduction to the concept of biomedical research, which means that instead of having impact on a single patient, that you might do research, make a discovery that could actually impact a large number of people. And I got bitten by that bug. So I had to make a decision whether I was going to go do clinical medicine or come back. So I actually split the difference. I did both. I came back to the NIH after my chief residency, and I made a deal with my mentor that I would do basic research, but I would also continue very actively to see patients. And I did that for about 9 years with a very successful career trajectory, which I would have thought end of story. I was going to do that until I stopped. And then along my line of life is expect the unexpected, something very unusual happened in 1981. That was the first cases of what would turn out to be AIDS appeared. And I made a very dramatic turnaround decision of my career. I left what was a very successful trajectory in a career to turn around, stop, and just focus completely on studying this group of almost exclusively young gay men who had a disease that was essentially killing every one of them. It didn't have a name. We didn't call it AIDS yet. It didn't have an etiology. But something about the disease, whether it was my empathy for the young men who were suffering from the disease, my desire to do something that was very challenging, my interest in a brand new disease made me change the direction of my career. And that's what I did. I changed in 1981. And then I started to realize that, and this was interesting for the global health people, is that global health was a non-entity when I was doing that. If you turn the clock back and go to 1980, 1981, there wasn't a discipline called global health. There were no schools of global health. There were no programs of global health, which was very interesting because I got interested in global health almost by accident, by my interest in HIV. I did not think that the federal government or my institute was putting enough resources in infectious diseases in general or in HIV/AIDS. I had the opportunity, as some of you may know, over the decades of advising 7 presidents of the United States, starting with Ronald Reagan. And he did not use the bully pulpit of the presidency to call enough attention to HIV/AIDS. So I think if he was to come back to life and do something over again, he probably would rethink that mistake that he made about not doing that. So I figured, how could I turn that around? And sure enough, expect the unexpected. The job of director of NIAID opened up. The last thing in the world I wanted to do was to do anything that had to do with administration. Exactly. I was a physician, I was a scientist, and the thought of administering anything just absolutely turned me off. But nonetheless, I figured maybe I could do something and be a different kind of an administrator, somebody who would administrate a large institution, but also would continue to be involved in clinical medicine and in research. So I was offered, and at was a very young age. I was the youngest person to be a director of an institute in the history of the NIH, but I took the job anyway. And when I took the job, I lobbied for and succeeded in getting the budget for HIV from like $30 million up to, over $1 billion over a period of time. But the one thing that the directorship allowed me to do was to appreciate what global health is, because I was responsible not only for HIV, which actually turned out to be a global disease more than a domestic disease. 90% of persons with HIV live in the developing world, and 67% live in sub-Saharan Africa. But I got very interested in the enormous impact of malaria and tuberculosis and neglected tropical diseases. And that's where I spent the next almost 40 years as director in getting very involved in global health programs, probably the most impactful of which was my involvement in developing the PEPFAR program, which is the President's Emergency Plan for AIDS Relief, which President George W. Bush asked me to be the architect of. And that's an incredible program that has had major impact. So I'll stop there and maybe you could answer any questions.
No, this is great. I guess a couple questions I'd love to. You mentioned how your Jesuit education impacted your decision in high school to think about medicine as a career. I guess I'd invite you to reflect, if you could, on how those Jesuit values. I mean, finally we got you at Georgetown after all your years at other Jesuit institutions, but I know those values have mattered to you. I guess maybe you thought about how they helped you make other decisions as you went through your career. Is that part of your thinking of why HIV, why some of the other trends?
You know, it had a lot to do with service for others. I was very, well, it's not just service for others, but it's service for others steeped in a manner of integrity, of high integrity of what you do. Right. And to give it everything you can for the greater good of others. And that has always been like built into me almost intuitively. And I'm pretty sure, because I try to examine, people try and, I don't like to psychoanalyze myself,
but we can if you'd like.
but there seem to be a lot of people that do like to psychoanalyze me, and people still scratch their heads saying, why did you leave an incredibly productive career in inflammatory disease, and you've developed essentially highly remission-inducing therapies for these autoinflammatory diseases? Why did you just stop, turn around, and start studying persons with HIV? I think it had to do a fair amount with what's built into a Jesuit education, besides the service to others and always doing it with a high degree of integrity, is empathy for those who are less fortunate. And I really was struck in a very empathetic way with these young gay men who had it tough, even if they didn't have HIV, right. Discriminated against, their families wouldn't accept them, the stigma associated with LGBTQ in 1981 Absolutely. Was infinitely more than it is today. And then to superimpose upon it, to have this mysterious, frightening disease thrust itself into your lives, killing, many of your friends, I just felt I needed to do something for them. And that's when I said, I'm going to make this my thing. So I decided, in the beginning, I didn't do much except I admitted the patients to the NIH, but they were so sick that I was spending, 80% of the day just taking care of desperately ill patients with very little time to do any meaningful research. So it was a strange period of my life, which I kind of describe as the dark years of my life, where, I was working 20 hours a day, taking care of patients, and then trying to do research, at 6 o'clock to 10 o'clock. But in some respects, as painful as that was, when we finally developed the drugs to completely turn around the lives of persons with HIV, to be part of that process, to go from nothing and everybody dying to 1996, 7, 8, 9, 2000, where you were able to give one pill to somebody and essentially have them lead a normal life. And then to realize that that's only accessible in the developed world, and then to have the fortune to partner with President Bush to develop the PEPFAR program to make that available for persons in sub-Saharan Africa and the Caribbean was quite a ride. I mean, it just went from way down to way up. Yeah.
but but those values did help animate it, that
I
direction.
mean, totally. I mean, it
it's a-
was driven by that feeling. I think, empathy and desire to help others, I think, were the two Jesuit principles that led it through.
I want to focus on a couple things before we turn it over to the students. One is about your role as an advisor to 7 presidents, and I think it's fair to say the last president you worked for was one of the most complicated ones.
No, the last one was Joe Biden. That was
That's all fair enough. The penultimate one.
The penultimate one. Right.
So maybe thank you. But actually, I guess it's a rare thing. In fact, I don't know of any scientist or health professional who's advised so many presidents, senior elected officials. I guess I'd ask you to reflect on what principles did you take to that exercise? What were your lines? And then the flip side is, what do you expect public officials to do? Like, you had a role. I guess I'd ask you to reflect on what's their role? How do they? Because they have to take into account things that are beyond scientific expertise. So I guess I'd love your thoughts.
Yeah, well, all 7 were different, but there was one, commonality of a principle that I strictly lived by, was based on, and I say this, a close friend of mine who was in the Department of Health and Human Services, but who had also spent 6 years in the Nixon White House. So we understood the White House and how the White House works. It's kind of like the Game of Thrones. But I would have hoped I came to this principle myself. I think I would have. I hope so. But he articulated to me. I was getting ready to go in for the first time to brief President Ronald Reagan about HIV/AIDS. And this person, Jim Dixon, told me, he said, I have one bit of advice for you. And I've lived by this for the last almost 40 years. He says, when you walk into the West Wing and go under that awning into the lower level of the West Wing, so the West Wing, you go on the level 4, and then upstairs is where the Oval Office is. So when you go into the West Wing, every time you do that, tell yourself, this may be the last time that I'm going to be going into this building, because you may have to tell the president and the people around the president an inconvenient truth that they don't want to hear. And his warning was, don't get caught up in the heady atmosphere of the White House that you want to get asked back so badly that you wind up telling a president or the people around him something that you think they might want to hear, as opposed to what the actual truth is based on science and data. And that's exactly what I did. And he said, one of 2 things is going to happen. You're going to do that, they're going to respect you for it, and you will absolutely get asked back. Or you will do that, and they will kill the messenger, and you will not get asked back. Or something that I hope you don't do, that you compromise your principles and tell them something they want to hear, and you might get asked back, but you will not be respected. So I lived by that of always going in there knowing I'm going to tell exactly what the truth is, give them advice based on data, based on science, and if it was inconvenient, it's inconvenient, but at least it's the truth. And that worked very, very well until the penultimate.
How did it work then?
Well, it worked pretty well in the beginning when I was telling him about, the fact that we were dealing with a very serious situation. But then when we got to around March and April, I would say the transition between March and April, when he realized that this was not going to go away, he started saying it was going to go away like magic, and I had to publicly contradict him. And then he was looking for magical solutions like hydroxychloroquine and ivermectin. And I had to publicly say that that's not going to work. And that's when we split. Yeah.
And so I would posit that the penultimate president handled it the wrong way.
Yeah.
But I also think it's fair. I guess I'd love some reflection on when have you seen presidents take the information that you provide them as a public health professional, but then weigh all the other considerations. Like as you know, I didn't work for President Bush, but I have enormous admiration for how he made a decision based on values and strategic opportunity that PEPFAR could be a great opportunity for both the United States and the people we serve. I guess I'd love how do you think someone as a president or what's the best way for them to take advice from a public health professional from you and incorporate it with all the other considerations they have to take?
Well, I mean, that's the reason why I have such a great deal of respect for President George W. Bush. I mean, it's interesting. I mean, a lot of people had a problem with him. Obviously, the Iraq War was a big issue. But when he asked me to go to Africa, I had been to Africa multiple times already, but he wanted me to go specifically after it was clear that we had drugs that could totally transform the lives of persons with HIV if you had access to the drug. And the triple combination of life-saving drugs began the era of highly effective antiretrovirals began in 1996. And then from 96 to the present time, it got better and better and better and went from multiple pills to now one pill that can induce remission, bring the level of virus to below detectable and keep it there indefinitely. That at the time that he and I started discussing this, it was in 2002. And he was interested to see if in fact it was feasible and accountable to be able to turn around both treatment and prevention and care, mostly in sub-Saharan Africa, but in a couple of Caribbean countries. So when he sent me to Africa, it was very interesting. He said, tell me, is it feasible and would it be accountable and how much would it cost? So I went to Africa and I got involved with many of my African friends at the time about whether or not they think this could be done. And I was convinced it could be. And when I came back to the United States and presented it to him, it was very, very clear that we were getting a lot of pushback from the budget people. OMB, when they used to see me walk into the White House, they would cringe because they knew I was going to be asking
lock the door.
Lock the door, keep him out. I mean, I was public enemy number one to OMB because they knew that I was going to be asking for something that was going to be measured in billions of dollars. And despite the pushback from that, he made a policy decision based on information I gave him. I said, we could do it. We could treat 2 million people. We could prevent 7 million infections, and we could care for 10 million people, including AIDS orphans. It would cost us $15 billion over 5. I scoped it all out with the help of Mark Dybel, who was my assistant at the time. And I presented to them and I didn't know he was going to accept it until literally the last week before the State of the Union address on January 28th, 2003. We know what PEPFAR is now. 20 years later, it's $115 billion, 50 countries, and saved 25 million lives. I mean, that is what a president who assumes leadership and listens to a physician, public health person who tells him something could be done, that's what could happen. It's amazing. Yeah.
So final question before we turn it over to the students. You mentioned you've had the role of as an administrator, physician, researcher. But the other role, I think it's fair to say, and I would say this to everybody in the room, I don't know of a single health professional I've ever worked with who doesn't agree that you're the best communicator of science that they know, including people who have fairly good-sized egos, I can assure you, who feel like they can communicate quite well. That's not a role, in fairness to some of even your colleagues at NIH, that people take on, but you did, and not just during COVID, but for many years. I think for future leaders in health, communications is going to be even more important, because we are in a world of a very complex communication ecosystem, and the ability to explain science and medicine is really critical. I guess if you might share with our students just some of your lessons about how to communicate effectively and with integrity and with purpose, and that would be great.
Well, John, I've developed certain core principles of communication, some of which come naturally and some of which I learned. One of them was, I'm trying to remember whether a Jesuit priest told me this or I told the Jesuit priest this. I wasn't quite sure, but it has to do with a saying that I tell my fellows when they ask me that question of how to communicate. And it's really called precision of thought and economy of expression.
It does sound like a Jesuit priest.
Exactly. Really, which means one of the principles is that first you've got to know your audience. And one of the biggest mistakes communicators do, they don't try and figure out who their audience is. And if you don't know who your audience is, you're going to lose them really quickly. You're either going to be talking down to them or above them, and you lose them. The second principle, well, there are multiple principles, but a second principle is once you know your audience, don't try to deliver 5 messages at the same time. Pick out 1 or at the most 2 messages and nail it with that. Because if you try to mix your messages and give multiple messages in a single session, very often people walk away and not know really what you're talking about. The other one, which is really very, very practical, that I totally adhere to, is that when you're communicating with someone, the purpose is not to impress the people how smart you are. The purpose is for them to understand what you're talking about. And scientists often make a big mistake. They get up and they start talking to people like they're presenting a paper in Nature or Science or Cell. And when you do that, nobody has an idea of what you're talking about. So if you do that and you have an audience of 100 people, 3 people will say, man, that guy's brilliant and he really knew what he was talking about. And 97% of them will say, what the hell did he say?
Exactly.
So if you abide by those principles, you could be a good communicator.
That's terrific. And so, as you know, we ask a couple of our students, they'll kick us off. They did the briefing emails for our whole class. So I'm going to start off with Leo. So do we have the mic? Oh, there we go. Terrific. And just as a reminder, since we have more fellows than we've had at other classes, so completely understandably, we'll first have a dialogue with the students enrolled in the class, and then if we have some additional time, I'll open it up to the broader group for conversation. So Leo, do you want to start us off?
Thank you so much. So the first question I have is, what lessons that you learned during the dark days of your HIV response most applied to the COVID-19 pandemic when we were in lockdown and you were trying to manage all of that?
Well, there are probably a couple of lessons. Let me see. One of them is that, getting back to one of the things that I keep living by is expect the unexpected. And that is that pandemics occur. Prior to HIV, the infectious disease community, and even some of the giants in the infectious disease community, felt that infectious disease was a discipline that essentially was outdated because we had vaccines and we had antibiotics. The thought of an emerging new infection was almost out of the question because there was, in my career in medicine up to HIV, there was no such a thing as a brand new disease. So what lesson we learned that in my lifetime, I saw the emergence of two absolutely brand new diseases. So the lesson is that pandemics occur. And be prepared for them, because even though we're sort of have COVID in the rearview mirror right now, there will be another pandemic for absolutely certain. We don't know when it's going to be. It may be next year, it may be 5 years from now, or it may be 50 years from now. But it will occur, and you have to be perpetually prepared for that. So a perpetual preparation for an unknown event that you don't know how, when, or where it will occur. That's one of the first lessons. The next lesson I think that's important is that when you have a cataclysmic public health event, it ultimately sheds light on many of the inequities in our society. We learned that with HIV, and we also saw it in spades with COVID. So if you look at the people who were they infected had a greater chance of being hospitalized and dying, it was those people, first of all, who had a greater risk of getting infected. So who had a greater risk of getting infected? African Americans and Hispanics, because they disproportionately were out in society with essential jobs, where people like me and John and you were sitting behind the computer, not getting exposed. The other things is the social determinants of health come out in an ugly way whenever there is a challenge to society like an outbreak. And I'll give you an example. So if you look at what are the underlying conditions that are much more likely to lead to hospitalization and death if you do happen to get infected with SARS-CoV-2. Now, obviously, age is a big determinant. And, you could be an aged white person or an aged African American. But if you look at underlying conditions, three of them that are the big three are obesity, big time high risk, diabetes, which is associated with obesity, and hypertension, which is associated. So it's kind of like a triad that goes together. And if you look at the incidence of that triad in minority populations versus Caucasian populations, white, it's disproportionately greater in that. So the lesson we learned was the same thing, that those demographic groups that are disenfranchised, economically a bit deprived compared to the others, and have a higher incidence of different types of disease and less access to health. A lesson from HIV, and I'll stop because I don't want to go too long on this question, but a lesson from HIV is a stunning lesson. 13% of the United States population is African American. 45% of all new HIV infections are among African Americans. So the naive but absolutely incorrect explanation of that is, well, that's because they're having more unprotected sex and their sexual habits are much different. That's absolutely incorrect. It's that the people who are getting infected, which are predominantly African American men who have sex with men, is due to a lack of access to health care, to prevention, to pre-exposure prophylaxis. If you look at the people who are on PrEP and look at the whites who are on PrEP and African Americans who are on PrEP, that has everything to do with stigma, and that has everything to do with a lack of access to care. So those two things, the HIV outbreak and the COVID outbreak, put a big spotlight on those things, and those are the lessons that you learn back and forth from one to the other.
Thank you. Like you said, back in the 80s, the HIV was something entirely new that no one was aware of and just sprung itself upon people. And similarly with the case with COVID. So what is kind of a public health risk that it exists, but people don't pay it any mind, or people are not really aware of? And is there a way to curtail it?
What is the next public health risk? Is that, you want me to predict that? No, I mean, it's a.
Would you do that? That would be great.
No, actually, it's a very good question, because there is a simple answer to it, is that it is completely unpredictable what it's going to be. When you talk about a public health risk that's infectious in nature, it is totally unpredictable. We had no concept at all that a coronavirus, which is, one of the viruses that's responsible for the common cold, all of us throughout our lives have been infected with the common cold coronaviruses multiple times, and we didn't even realize it. We had a few sniffles, blow your nose, have a sore throat, and then you're done. We never would have, we should have suspected, because in 2002, the original SARS came. We had 8,000 cases and 785 deaths, but we were able to contain it with good public health measures because it wasn't easily transmittable from person to person. But we should have been, we were, but it just happened. We should have been expecting that sooner or later we're going to get another coronavirus that would be pandemic. But the public health risks from an infectious disease standpoint, people have asked me for decades, what is your worst nightmare and what keeps you up at night? And I am on record. You could probably go to YouTube and find it somewhere from 20 years ago. I was saying the thing that keeps me up at night and is my worst nightmare is a brand new infection that jumps from an animal reservoir to a human, that's respiratory borne, and that is highly transmissible and has a high degree of morbidity and mortality. I said that 100 times over the years, and we are now in the 5th year of my worst nightmare, which is COVID, which is exactly that, a brand new virus likely jumping from an animal reservoir to a human, highly transmissible, and at least in some people has a high degree of morbidity and mortality.
Excellent. Naomi?
Absolutely. Thank you so much. As someone starting out in science journalism, I'd like to focus back in on science communication. Here at Georgetown, just last year, we started a section in the newspaper, the student newspaper, dedicated to reporting on health and science. But we quickly found that it's not always easy to recap or translate what public health officials are saying to kind of a broader audience. There are a lot of pitfalls in journalism. So in your experience, what are some things that journalists did well and some things journalists did badly during the COVID-19 pandemic?
Mostly they did things well. One of the problems, and you want to be a journalist, do you really? Okay. No,
So I told you we had a wide range of students.
I'm pleased to see that you want to be a journalist. So if I might be so bold to alert you to a trap you don't want to get into, is that one of the problems with journalism, and I guess it's an unavoidable problem, is that you try to have a balanced story. And when you try to have a balanced story, you want to get multiple opinions in a balanced story. And what's the right word? What trap you get into when you do that is that you can often lead to the audience getting a feeling of false equivalency. So you could say, well, Tony Fauci says that you should get vaccinated, the vaccines are safe, and they're highly effective. And I have an MD, and I'm in the National Academy of Sciences and all that. Then you look for someone who has equivalent qualifications, and they says, no, vaccines don't work, and they kill you rather than help you. And in your quest to be fair, you leave it up to the reader to figure out who is right and who is wrong. And I think that's a trap of journalism that you really got to get away from, because you create a false equivalency. And the most egregious example of that was in the 1980s when HIV was discovered and we had our first therapy with HIV, which was AZT, which helped a lot but wasn't the end all because it was only one drug. There was a professor at Berkeley and a couple of his colleagues at Berkeley, at Stanford. I mean, you couldn't get better than Berkeley or Stanford, right? Well, they got up and they said that HIV doesn't cause AIDS at all, and it's the medicine that you're giving people that's making them sick. So they kept on saying that, and the public, you know, they just hear about this, and journalists like yourself gave them a bully pulpit to talk about it. So I got asked multiple times at the time to essentially debate this person. And that's what the press created, was false equivalency. Tony Fauci, NIH, National Academy of Sciences, Peter Duesberg, Berkeley, National Academy of Sciences. And they had us argue, and I gave them all of the absolute data why HIV caused AIDS. And I can tell you that people who were listening, not all of them, but some of them, went away saying, you don't know who to believe. You know, I could believe one versus the other. Now, that's okay, except that the story went on, and Duesberg began to talk about that a lot. And in South Africa, the president of South Africa, Thabo Mbeki, who did not want to supply drugs to the people of South Africa, he believed, maybe, but he acted like he believed Duesberg. And for a couple of years, drugs that would have been available to South Africa were not available. And they did a modeling study to show that the time when combination of drugs should have been available to South Africa, they estimated that 300,000 South Africans died because they didn't get it. False equivalency. So
Your advice
remember
is
that.
noted. Thank you.
So this is you're speaking to the journalists of tomorrow. Please.
Thank you. I will just say, if I'm allowed to, when she says Georgetown started this thing in La Jolla, it was her. It was her single-handedly. So one of the things I wanted to ask about, and it was hard to choose, is you talked a little bit about the role of stigma, particularly in HIV.
The role of
Stigma.
Stigma, yes.
Yeah. And so this is something that I've kind of been looking a little bit at, looking a little bit at as I've been at Georgetown, and I'm hoping to when I graduate in May. And so I'm kind of curious about, you've mentioned kind of preparing for the next pandemic, addressing social inequities now while we have the chance and while we're aware of them. And I'm curious what role you see stigma playing in this. Like what ways, maybe institutionally, maybe socially, can we go about addressing stigma, both about HIV but about other diseases, so that it stops having such a strong grasp on people and affecting the way we respond in the future?
Yeah. You know, that's a great question, but it is really no simple answer of how you address stigma from people who feel that there's a stigma associated. I think the only way to do that, and it's going to take a lot of effort, is to speak out frequently and coherently against stigma. The way we did early on during the HIV years, when we really very, very actively and proactively spoke against the stigma of particularly young gay men. I think we're partially successful. I mean, some people who are going to be prejudiced and be stigmatizing, no matter what you tell them, they're not going to change. But I think we did make some headway by essentially accepting and normalizing the people who are getting stigmatized against. And the more people like you and I do that, the more you can counter stigma. But it is really a very nefarious trait, stigma. It's insidious. People have it and don't admit they have it. So it isn't as if you can identify somebody says, I stigmatize people. They don't do that. but you should assume that it's more prevalent than you think. So don't give up on trying to fight against it. You're graduating in May?
Barring any major changes, yeah.
What are you doing next?
Oh, that's a great question. Well, I'll let you know.
Okay.
Terrific. Hannah?
Yeah, so there are disease outbreaks and even like localized epidemics that happen every year. But my question is, what are indicators that the threat may become globalized rather than just stay localized? Or I guess in other words, what would alert you to brief a president about an outbreak that's occurring?
Yeah, that's a good question. It's the characteristics of what the pathogen is, and that is really a real world example of how early misinformation and disinformation didn't allow the world to be as prepared, at least in the first few weeks. By the time you got out into the first couple of months, all bets were off. But in the first week or so, the information that was coming from China was that this was not a particularly easily transmittable virus, that it was similar to the original SARS of 2002, which was so inefficiently transmitted that mere public health measures could contain it. So if you have a virus that is not easily transmittable, the chances of it exploding into a global pandemic are really very, very small. If you have a high degree of transmissibility of a respiratory virus, then you got to put the real red flags up that something is going on. It wasn't until the second and third and fourth week did we finally get information from China that first it was, oh, it's poorly transmitted. And then, it's probably pretty well transmitted from person to person. Then the next week, it's really, really very well transmitted. And once we knew that, then it became clear we were going to be dealing with a global pandemic. It was a very, very strange, and it's very difficult to get the general public to act like you're dealing with an explosive pandemic before it explodes. So, for example, the first case in the United States was in January the 20th. And if you looked at what was going on in China, we saw that the Chinese were building 1,000-bed hospitals over a weekend. So you say, wait a minute. If you're building 1,000-bed hospitals over the weekend, something really bad is going on in China. And we were having the infection here, and we started to see inklings of community spread, namely spread from one person to another without there being any symptoms of knowing what the spread was. If at that time we told everybody to wear a mask and stay socially distant from each other, the country would have said you're crazy. No. Even though you kind of knew based on what was going on someplace else. And the only time we started taking it seriously was when Italy exploded. When I say exploded, northern Italy had such a tsunami of cases that they couldn't handle it. And we were saying, some people were, not me, for sure, well, if it comes here, we'll be able to handle it with identification, isolation, and contact tracing. And our Italian friends were saying, no, trust us. This is really, really bad. And to be presumptuous to think that we could handle it any better than Italy could handle it was really presumptuous. And then when it came here, we saw what happened here. We had overwhelming our hospitals. Yeah.
Ethan?
Yeah, thank you so much for your time. You spoke a lot about misinformation as it relates to HIV, and I was wondering if you had an opinion on the prevalence of artificial intelligence and its impact on misinformation, especially with the creation of things like deepfakes.
Yeah, well, artificial intelligence, as I'm sure you're aware since you asked the question, artificial intelligence can be very, very productive in the field of health and in medicine. I mean, some examples we know that, in reading biopsies and x-rays, they generally do better than a radiologist or a pathologist. But it is also the danger that what you're alluding to, that artificial intelligence that gets out of control can really, really magnify misinformation and disinformation. There's a funny thing that Ron DeSantis's campaign, when he was doing his anti-Trump thing, he did an artificial intelligence thing of having me hugging Donald Trump and saying Donald Trump loves Tony Fauci, therefore don't vote for Donald Trump. And it was a purely AI generated picture. Yeah. So I understand the AI. Yeah.
You've been done. Any burning follow-ups from our core class before we turn it to the rest of the?
Well, you missed somebody, I think.
Well, you're one of the fellows, so we'll get there.
Okay.
Can I just I'd like to ask one question before you open it up, Tony, which is, over and over again in your answers, you talked about the need to persuade public officials to act now, or to prevent, or to invest now, whether we think about perpetual preparedness. It's the hardest thing to do, right? Is to get government to invest money now to prevent something that might happen in the future.
Right.
Even if it's catastrophic, if it's a relatively low risk. But you've made this case time and time again, and I guess just thoughts about what you have found persuasive in moving public officials in preparing now, spending money on prevention now.
Yeah, I mean, to be quite honest and humble, I haven't been that successful. I've certainly mobilized resources during the crisis, but I have found that corporate memory is very, very short-lived. And as we came to the end of the crisis period of COVID, and I don't want to say the end of COVID because we had 342,000 infections yesterday, so it isn't like it's over. But during the time when the hospitals were being overrun, everybody was very enthusiastic about putting hundreds of millions, if not billions of dollars in. As soon as things calmed down, we put together a program for the next generation of pandemic preparedness. We asked for something like, $80 billion for it, and it went absolutely nowhere. And one of the things that I wish I could have been more successful in, but I wasn't, is when the crisis is over, is to get people to be enthusiastic about it as they were in the beginning. And that's just human nature, because government in particular, that has so many demands and so many challenges, will focus on what the immediate need is, not what you're going to be prepared for 2, 3, 4, 5 years from now. So it's really a tough nut to crack to get policy makers to sustain. Well, we'll take a look. The global fund with the new budget is cut by 40.2%. I mean, come on.
And the reason I ask this is, you've heard this from our other speakers, the challenge of so much about public health is to invest in the future, invest now in a way that can make a difference in the future. That's very hard to do because there are so many other competing priorities. So I don't see any burning questions here, so I'm going to open it up to our fellows. And I know at least one here, but why don't we, there's several. All right, so let's try. All right, we got a few minutes here, so why don't we start here, and then I'll come over here to 2 or 3, please.
Thank you so much for your time. I guess in connection with that statement about investing now for the future, in your perspective, what would you think is beneficial to bring something into importance if the cause of the illness or the construct isn't necessarily not just a biological component, but there's also a psychological and social aspect to it, especially if, let's say, that issue is not necessarily something that is linearly cured, but more so, let's say at that time, COVID, we remember we're not sure on how to cure it, But let's say we have something similar like that in the future, but the only thing that we can do is maintain the severity of the issue itself.
So, I'm sorry, what's the question?
Yeah, what's the question?
So, like, in your perspective, like, let's say in the future, I think I'm interested to see your perspective on, let's say, issues like neurodevelopmental issues.
Neurodevelopment.
Yeah,
right.
like kids with like intellectual disabilities and all that stuff. In your perspective, if let's say they don't have just a genetic component to it, and there's also like an environmental factor to it, how do you think you can convey that to the public to make it into importance?
How do you raise the salience
Mhm.
of issues like neurodevelopmental disorders?
Well, neurodevelopment disorders, I think is a tough nut to crack to get people that interested in it. But, you don't give up. If that's the area that you're interested in, you may have to put a little bit more effort because people will not identify with a neurodevelopmental disorder if they don't have one. If you're trying to get people to worry about getting an infection that's going to kill them, they're worried that they're going to get the infection that's going to kill them. So that's one of the problems you face, and that's where you have advocacy. And advocacy groups can be highly, highly effective in getting resources for and support of something that doesn't turn on the general public because they're not worried about it for themselves. So I think the answer to your question is a perfect run-on to the importance of advocacy groups to call attention to the less common issues that don't capture the imagination or the fear of the general public. It's amazing what fear of involvement that of your own. Everybody is afraid of getting cancer. Okay, show me somebody who doesn't once in a while think about maybe have a cancer in me that I don't even know about. I mean, so that's different than a neurodevelopmental abnormality.
And I would just say, as you think about your advocacy careers, there are many different roles in public health. As Dr. Fauci indicated, there are literally advocacy groups for hundreds, if not thousands, of diseases because of the very challenge you've identified. A serious issue that faces a relatively small group needs even a more focused advocacy effort. So, well, let me turn this I didn't see that. Oh my gosh, we got all right. Let's start right here in the middle, please. Yep.
So I'm taking a class called Follow the Science, Medicine and the Law, and we discuss the role of not only lawyers in that class, but also public health officials like yourself. And so my question is, do you think that the current system that we have for public health officials to advise senior executives like the president and his cabinet is sufficient enough for the public health crises that we had in the past, such as HIV, AIDS, and COVID-19, or sufficient for pandemics in the future? And kind of connected to that is, in your position, in this position that you've had, has the role of lawyers been helpful or harmful to you? And should that also change? Thank you.
Okay, so there's a couple of parts of your question. So take the first part about public health officials influencing and having an impact on a president or the people around the president. That is something that is totally at the discretion of how much a president wants to hear from public health individuals. And in my 7 presidents that I've had the opportunity to advise, there's been different enthusiasm about hearing directly from public health officials. A particular note, I was appointed by Joe Biden for the 2 years I was with him to be his chief medical advisor. He wanted really to get involved in knowing all of the ins and outs of the details of public health issues, particularly centered around COVID, because, during his presidency, when I was there, COVID was still a very big deal. But it really depends on the president. Some who, like during the Reagan administration, he was not fazed at all by the public health implications of COVID, which is unfortunate. It wasn't until George H.W. Bush became very interested in that, and that's when the resources for that. Your question about what role or help lawyers would be.
What do you think?
It really depends.
I know you know some lawyers.
Yeah, I know a few lawyers. Yeah. Well, I can tell you, they weren't acting like lawyers, but they were lawyers, is that during the PEPFAR discussions, that when I was putting together the program for PEPFAR, there were 3 or 4 people in the White House who were incredibly helpful to me. One was Josh Bolton, who's a lawyer. One was Jay Lefkowitz, who was a lawyer. And one was Gary Etzen, who was a lawyer. So 3 lawyers who were not giving me legal advice, but were very, very good at knowing what can or cannot be done in the legal sphere of the government legal issues. What can you or can you not do with a piece of legislation? So I've had very positive interactions with people with a law background in the White House.
So I think I got one. Did you have your hand up here? Oh, right, please. Yep.
Hello. I know you talked about the HIV epidemic as well as tuberculosis and working with malaria in Africa. But can you talk about your experience with the Ebola outbreak and what were some things that you learned from this that were different from previous outbreaks, as well as something you wish you knew going into it?
Well, the Ebola outbreak was very, was unique. It was the West African Ebola outbreak, had 18,000 people and 11,000 deaths, I think it was. So it was historic, the worst ever in the history of the West African outbreak. The thing about Ebola that is different from a global health and public health standpoint than influenza and bird flu and COVID is that the nature of the way Ebola is spread from person to person would make it almost impossible to have a generalized outbreak of Ebola in this country or any country with a good healthcare delivery system. And you ask an interesting question because that was not fully appreciated during Ebola when we had one case of a man who came in from Liberia who was infected, did not tell the people at the airport when he arrived that he had contact with a person with Ebola, got infected in Liberia, came here and infected 2 nurses, one of whom I actually personally took care of at the NIH, that the country was in a roar. Well, we're going to have a big outbreak of Ebola, but that was impossible. There would not be any way. So it gets back to, I think, one of the questions somebody else asked me is what is the nature of the transmissibility of an agent is when do you start thinking that you're going to have a global impact? And Ebola never, ever rose to that occasion. Ebola is a very scary disease for the people who have it and the people who are taking care of the people who have it. But it is not a global health threat.
Let's see. How about Erica? And then.
Hi. PEPFAR it took longer to reauthorize PEPFAR this year, which is not normally the case, and it's been reauthorized for only 1 year. So with the possibility of an administration change, I was wondering what you personally thought or how critically do you think domestic concerns and controversies around reproductive health will affect relevant programming in like USAID, HHS, and state?
Yeah, I mean, if we have a change of administration in the wrong way, I think it could have a really negative impact. I was very disturbed by the 1-year reauthorization. And the reason for that was, the concern of a very small core of Republicans who felt completely inappropriately and incorrectly that PEPFAR was essentially a road towards abortions. And to me, that is really unfortunate and a bit of a disgrace that a program that has saved 25 million lives is being hampered in its authorization by people who are completely misinterpreting. I mean, so I'm for pro-life. I don't like abortions, but I'm going to hinder a program that has saved 25 million lives. I mean, just I don't even want to begin to tell you how I feel about that. Yeah, so we've got to really be careful when voting matters. Administrations matter. I'm very concerned about some of the things that we hold near and dear in public health and in global health, that if we do have a change of administration, it's not that if Trump becomes president, that he personally is against something. He just hires a bunch of weird people who really are, don't make sense to what you and I think about.
See, I think a question here.
Hi, yeah, my question comes from getting a lot of information from my biology professors and in my biology research labs. There's a constant emphasis on the fact that there isn't a complete truth ever in science, and kind of this constantly approaching knowledge and scientific uncertainty playing a large role. How do you balance that as a scientist in a time of crisis like with COVID-19, when politicians and the general public want really definitive, clear answers as to what they should be doing and what isn't true?
Okay, so that was a big issue in the evolution of COVID. So you've got to make sure. Are your biology professors giving you a hard time? Is that? They are? They are. All right. So science is a process of, it's a mechanism. It's a process of collecting data so that you can then act one way or another on the given data. What people who talk about the uncertainties of science, I think, fail to understand that it isn't there are uncertainties of science, is that science, by its very nature, is self-correcting. So you use the scientific method to get certain information, and at a given time, that information is correct. But when you're dealing with a moving target, the way you often are, a month or two later, the information might change, and the scientific process leads you to that information. And if it's different than here, it's the beauty of science to get that information to tell you that something has changed. And the people who are anti-science say, well, scientists just keep flip-flopping. Scientists are not flip-flopping. Scientists are using the process of science to gain information. Let me give you, I can give you 20 examples. Let me give you one. So you start off in the beginning of COVID, and just the way I was alluding to before, we thought that the virus was not transmitted very easily. And then you became aware that it became transmitted very easily. So the recommendation for better ventilation, for masking, for social distancing is much different than if you're dealing with a virus that's not easily transmissible. You have the standard paradigm of flu. You get a flu pandemic. You get one virus, it peaks, it doesn't change, and then it goes away. When you're looking at the first few months of COVID, you're looking at one ancestral strain. So it is reasonable to assume that that's going to be the virus that you're going to be dealing with for the next few months. What happened? You had multiple variants that occurred in the same outbreak. It was the self-correcting nature of science that told us, wait a minute, this is really different. We're not having one ancestral strain, we're having variants, and each variant eludes the protection that you get from the previous variant. Science tells us that. Does that mean that science is wishy-washy and doesn't give you the truth? No, it's because science is continuing to self-correct to give you the right information at the time. So go tell your biology teacher to go stuff
You
that.
guys think exactly.
Yeah.
I think we got everybody. Oh, there's, okay, son, how about one more? Because I think that, I'm sorry, this will be the last one. So.
Yes, hi. So, in talking about preparing for future pandemics, you talked about ways in which we could reduce social inequalities that exacerbate those disparities that have been seen in past pandemics. So, I was curious as to what some of those tangible strategies would look like, and what kind of the implementation landscape would look like for that.
Yeah, it's a good question. So there are things that you can do immediately, and there are things that are going to take decades to change. So the things that you can do immediately is that you can increase access to interventions, to clinical trials of minority populations. We did that when we conducted the clinical trials for the COVID vaccines. Of course, left to their own devices, the pharmaceutical companies that were very heavily involved with us in testing the vaccines would have 1% African American, 2% Hispanics in the clinical trial, which was complete inequity in knowing what the specific effects would be on that population. So 13% of the population is African American, 18 to 20% is Hispanic, and you were having 1 to 2%. So we changed it immediately. We said, you're not going to continue with the clinical trial unless you get proper representation. So you could turn that around completely and quickly. The thing you can't turn around that's going to take decades of investment is to counter the social determinants of health. The fact that if you are an African American of a certain age, the chances of you being obese, the chances of you having diabetes, and the chance of you having hypertension are far greater than the general population. The reason for that very likely relates to the time of their birth, when they don't have proper diet available to them because they live in an area where you don't have a store that sells good food. You're eating junk food from the time you're a child. That's when you get obesity, that's when you get diabetes, that's when you get hypertension. That, unfortunately, relates back, and a lot of the far-right people don't like to hear me say that, but it's true. It relates back to fundamental racism, where the opportunities to have economic availability of bringing yourself up economically, the opportunity of having access to good health care, where somebody takes your blood pressure so that you know you're hypertensive and you get on a medication, as opposed to presenting in the emergency room with a stroke, which happens to a lot of minorities because no one ever took their blood pressure. It's those kinds of things. But those are the things that are not going to change overnight, because you can't just do something about that. You've got to change the whole societal approach towards people who are in that category. And that, I think, is going to take decades. That gets back to what I was telling to John. You know, you can change some things easily, but if you don't have a long-term commitment to change it, it's not going to change.
That may be a good place to bring this to a close. And I think, first I want to thank you, Tony, for doing this. I will say this, I think we met almost 30 years ago, probably, in the Clinton administration. At that time and through all the years, I can't think of anyone in public life who modeled integrity and the commitment to public service the way you have. But the most important thing, and I would say that since we were all here and we've all come through the security here, is the other part beyond integrity and service is courage. The willingness for our country and for the greater good to speak the truth and to keep talking and tell, and it's something I really admire. Thank you. So I guess, as is our custom, I would ask everyone to join me in a round of applause for our speaker.